idea of this presentation is not to demystify the conventional knowledge regarding LipiTension, but to provide you a glimpse of what is the vision ahead, what you are going to see in future. All of us know cumulative exposure of lipids or hypertension, that is blood pressure, to the vessel wall is one of the most major determinant of macrovascular disease. More is the BP load, more is the LDL load, and in diabetics, more is the glycemic load. There are more chances of development of microvascular disease. So we are always concerned regarding the cumulative exposure. And all of us know LDL is the major culprit for ASCVD, but if you want to have the benefit of LDL lowering, you have to consider LDL lowering as a lifelong marathon. And you have to run this cardiovascular highway from early age to less than 70. The reason being that if your LDL is less than 70, there is a rest of atherosclerosis. Atherosclerosis will not progress. So if you are running this marathon from very early age, you will not. But if you continue to run, you are unlikely to develop subclinical disease and unlikely to develop myocardial infarction and get stented. But you have to run this along this pathway for the whole life. Unfortunately, if you get entangled with an acute myocardial infarction, get stenting, it's late, but then whatever is the remaining cardiovascular health highway, you have to run with LDL at least less than 50, because at level 50 there is regression of atherosclerosis, and if you are a very, very high risk, means you have polyvascular disease, diabetes, multiple organ damage, maybe 30. But when we look at the options available for this continuous lowering of LDL, whatever option you choose, even if you choose inclisiran or whatever, compliance is a big, big problem. Very difficult for an individual to be compliant with any of these drugs for several years, which is usually lifelong. So what is the solution to this? The solution to this is provided by gene therapy, which is now CRISPR-Cas9 technology. Now this has two components. As you can see, there is a guiding RNA which locates the specific gene. Here it will be PCSK9, and the Cas9 produces a double-stranded break in the genomic. So let's see the video. Now you will see that the guiding RNA has located the gene, and the Cas9 has produced a double-stranded break in this PCSK9 gene. So when this gene heals, it loses its function. It becomes a case of loss of function mutation of PCSK9, and your LDL is lowered to the rest of the life. Here you can see the Verve 101 trial data. PCSK9 levels is reduced by 89%, normal being 35 to 225, and LDL by 68 for the rest of the life. So the beauty of this technology is a one-time treatment, one infusion, and your LDL is lowered. Just we have a loss of function mutation, a genetic abnormality also. These patients live very long because the LDL is lowered for the rest of the life. What is the vision ahead with LPA? LPA, all of us know, it is a deadly disease. It is considered even a slow death sentence because of early onset of atherosclerotic cardiovascular disease. There is also associated atherosclerosis, though approved treatment. So all of us know that LPA was described in 1963 by K. Berg. But for last 62 years till date, no approved drug exists to LDL, LPA lowering because it is genetically determined, and therefore the answer has to come from gene therapy. And again, gene therapy is making a great success. And therefore, gene therapy, when we are talking of an LPA-induced cardiovascular disease, it has utilized two technology, an antisense technology, but an ASO technology, antisense oligonucleotide, and a small interfering RNA. Now, the drug which utilizes this antisense technology is pelacarsen. The Horizon trial is near completion, and early next year we are likely to get the results, and hopefully this may come out to positive. Now, when you inject this pelacarsen, which is a GalNAc conjugated hepatocyte specific antisense to ApoA, it reaches liver because the hepatocyte specific, reaches the cytoplasm and the liver and combines with the messenger RNA. And once it combines with the messenger RNA, the RNase cleaves it, destroys the messenger RNA. If messenger RNA is destroyed, it will not be able to synthesize ApoA, and ApoA cannot be synthesized, LPA levels will not increase, will decrease. So this is the concept of pelacarsen. The other technology which is being used is small interfering RNA, and this also works on the same. When you inject this agent, it combines with the messenger RNA, destroys it, and therefore ApoA cannot be formed. Now, this is the future of LPA. As we said, the Horizon trial is ongoing, likely to be completed, and pelacarsen decreases LPA by 80%. Interestingly, three small interfering RNAs, olpasiran, lepodisiran, and geladisan, they are in late stages of development. They decrease LPA by 90%, or even some of them 95%. And we have an oral molecule also, you can see at the bottom, ovaliprin, which decreases LPA by 65 to 70%. So the future of LPA-induced cardiovascular disease is going to be bright. So all of us know LPA-driven cardiovascular disease is considered a slow death sentence with a gloomy prognosis like this, because premature development and malignant progression of ASCVD and aortic stenosis, and currently lack of any approved treatment. But if pelacarsen and small interfering RNA trials, they come out to be positive, hopefully they may, then LPA-induced cardiovascular disease will become a salvageable disease in future, and this will kick off a new dawn of LPA therapeutics, which is not existing at the present state of time. And this vacant place very likely to be occupied by pelacarsen if the trial comes out to be positive. Otherwise, except for FRSS, we don't have any approved drug for LPA. Hypertriglyceridemia, again, gene therapy is encroached already, the drug is already approved, and this also works on the antisense technology, antisense to ApoC3. All of us know if the ApoC3 level is decreased, you will have decreased triglycerides. And the first drug which was tried was volanesorsen, but not approved by FDA because it produces bleeding because of low platelet count. But olezarsen has been approved by US FDA after the BALANCE trial. It is approved in February 2025, likely to be available in future. And a single dose of 80 milligrams subcutaneously, the effect lasts for 30 days, and you can see the reduction in triglycerides is to the tune of 43%. So sometimes when we have this genetic hypertriglyceridemia difficult to control with other drugs, this may be a boon to these patients with severe hypertriglyceridemia. Mixed dyslipidemia, the diabetologists are very much interested. They see every day, again, gene therapy is encroached, and here it is small interfering RNA to NPTL3. And you can see this was the prolonged trial. Phase 2, you can see substantial reduction in triglyceride, VLDL, LDL, non-HDL. So we are amidst a new era of lipid management in gene therapy, which never existed before, and time has come to rewrite the script of lipid management. At the moment, if you read chapter on lipid management, gene therapy is virtually missing, but now is the time to rewrite the script of lipid management because of these advances. The second component of LipiTension is hypertension. The biggest problem in hypertension again is we have therapy which has to be taken daily. We don't have, unlike lipids, once monthly or twice monthly or once 6 monthly. You have to take the tablet daily, and again compliance is a big problem. Very difficult for any patient to be compliant throughout his life or maybe for many years. So here again blood pressure now takes a vacation, and this vacation is for 6 months. We have zilviceran, again a small interfering RNA, single injection, the effect lasts for 6 months. So get one injection, the effect will last for 6 months. The principle of this small interfering RNA, it inhibits the synthesis of angiotensinogen in the liver. So angiotensinogen synthesis is decreased, RAS activity is decreased, and the blood pressure decrease. The Cardia 3 trial was presented recently, ESC, and you can see at the end of 6 months the blood pressure decreased by 7.4. This is the ambulatory blood pressure recording at the end of 6 months. You can see substantial reduction in daytime, substantial reduction in nighttime. And if you are on diuretics, the fall in blood pressure is much more. The phase 3 trial is ongoing to see what would be the impact on the cardiovascular endpoints. We have 2 new drugs for hypertension. Aprocitentan, which is already approved in March 2024, likely to be available in India soon. Endothelin is the most potent vasopressor, and when you block endothelin A and B, it becomes a potent antihypertensive drug. The precision trial was conducted, and you can see substantial reduction in the blood pressure in the part 1, then it was maintained, and when the drug was withdrawn and compared to placebo, the drug continued to have sustained reduction in blood pressure, and as expected, the placebo levels, placebo group, the blood pressure has risen. Ambulatory tracing, again significant reduction in blood pressures. So this is going to be a useful addition to the therapeutic armamentarium of resistant hypertension. The only side effects are edema and fluid retention, which is taken care of by diuretics. So we'll hurry up. Aldosterone synthase inhibitor is again a new drug. Unlike aldosterone receptor antagonist, has minimum side effects, and the drug is better, just 30 seconds. You can see substantial reduction in the blood pressure, systolic as well as diastolic. Again, you can see over time. Device therapy, we have now this carotid baroreceptor stimulation, decreases sympathetic activity and increases vagal activity. And lastly, the renal denervation has been approved after a long time, but still has a 2BB recommendation. So in summary, LipiTension is an important determinant of atherosclerotic cardiovascular disease. Besides lifestyle modification, drug therapy no doubt plays an important role, but compliance is a major problem because it has to be taken for several years, maybe lifelong. Gene therapy is going to revolutionize the treatment of both lipids and hypertension, is going to minimize the problem of compliance. Gene therapy is likely to come as a rescue even for an LP-induced cardiovascular disease by pelacarsen, small interfering RNAs, and zilviceran decreases the production of angiotensin once in 6 months, is going to revolutionize the treatment of hypertension. And we have 2 drugs, aprocitentan and batroxad, and device like carotid baroreceptor stimulation and sympathetic dynamics. Thank you very much for your kind attention.